My name is James Hargreaves. I've been involved in Strive from the beginning and have co-chaired one of the working groups on the interaction between structural forces and biomedical HIV prevention. So I've done a few of these, although inevitably they're always plagued by some kind of technical demons. For those of you who are joining us from outside Strive, Strive's a research consortium. It's funded by DFID here in the UK and it's tasked with tackling the structural drivers of HIV through research. It involves partners in India, Tanzania, South Africa, the US, which is where Anne joins us from, and the UK. And the group as a whole has spent the last, I think now 8 years, something like that, conducting research into a range of structural factors that influence the HIV epidemic, including alcohol use and transactional sex, gender norms, stigma, and violence. And so today's Learning Lab is, as I've said, from our colleague Anne Stangl, who I've known a long time now through the whole of Strive and before, and she's going to present some new work. It's a cross-cutting framework that seeks to articulate the stigmatization process across a series of domains and show how that framework can help in research, programming, and policy efforts. So in a second, I'm going to hand over to Anne, who I think is in control of the slides. She's going to give the talk. Anne, about how long are you going to talk for?
Okay, 30 minutes. You can hear me now?
Yes, we can hear you beautifully now.
Oh. Okay, good.
We couldn't hear you at all before, but that's great. So Anne's going to talk for about 30 minutes, and then we'll afterwards there'll be a questions and discussion. If you're on Ready Talk, you can feel free to type questions into the chat box, and people will be able to ask them verbally at the end. So that's great. Over to you, Anne. Thanks very much.
Okay, great. So good morning and good afternoon and good evening, everyone, depending on where you're calling in from. I'm going to be talking to you today about a new framework called the Health Stigma and Discrimination Framework that just came out in a BMC Medicine special collection on stigma and global health. This framework is really sort of is the culmination of many, many years of work and research by myself and others, and much of that done through the Strive Consortium. So I just want to go quickly through the format of the presentation. Firstly, I'm going to give some background context, talk about some key definitions of stigma, give you a brief history of the framework, and then I will talk about, I'll give you an actual overview of the new framework, discuss some practical applications and how we might use it, and then we'll open it up for questions and discussion. So before we begin, I just think it's important to remind ourselves of why stigma is so important in the broader context of health and development. First and foremost, the experience of stigma is an infringement on our human right to live a life free from discrimination, which is enshrined in the Universal Declaration of Human Rights. In Article 2, it states that everyone can claim their rights regardless of sex, race, language, religion, social standing, birth, or status. And stigma, we know that stigma often interferes with people's ability to access healthcare and other social services, and particularly for marginalized populations. So it can really impede health and development globally. Secondly, stigma influences population health outcomes by worsening or impeding a number of processes that exacerbate poor health. And these include social relationships, the availability of resources, stress, and psychological and behavioral responses. And lastly, recent research, including in one of the papers in the supplement, the BMC supplement, we know that that internalized and experienced stigma are linked to poor physical and mental health outcomes across a range of diseases. So this is really an important issue that we need to tackle in order to improve health and development globally. So next, I just want to talk briefly about sort of pivoting to HIV stigma for a second. I want to talk briefly about why it's important to mitigate HIV-related stigma and discrimination. So almost 2 decades of research have demonstrated that HIV-related stigma and discrimination hamper efforts to prevent new HIV infections. and engage people living with HIV in care and treatment. And as a result of this, there's now a general consensus that interventions to reduce HIV-related stigma and discrimination are really critical to the success of existing and emerging biomedical prevention technologies. And lastly, just the importance of stigma reduction has also been noted now by influential bilateral and multilateral organizations. For example, HIV-related stigma reduction is a key priority of PEPFAR's blueprint for achieving an AIDS-free generation. So I think it's generally recognized that it's important for us to address HIV-related stigma. So now I just want to review with you a few definitions. I'm not sure how familiar everyone is on the phone with stigma, so I just want to go through a few basic definitions. So what is stigma? I find it helpful to start with the very first conceptualization of stigma by sociologist Erving Goffman. He defines stigma as an attribute that's deeply discrediting and that reduces the bearer from a whole and usual person to a tainted or discounted one. That leads to disqualification from full social acceptance. He goes on to highlight the really insidious nature of stigma when he says, by definition, of course, we believe the person with the stigma is not quite human. On this assumption, we exercise varieties of discrimination through which we effectively, if often unthinkingly, reduce his life chances. It's important to note that Goffman mostly focused on the individual in his conceptualization of stigma. But stigma actually emerges through a dynamic social process that begins when a difference is labeled, followed by negative stereotyping because of that difference. Then a separation of us from them occurs, and that's followed by status loss and discrimination. And this process was outlined by Lincoln Phelan back in 2001. So the stigmatization process is enabled by underlying social, political, and economic powers that seek to devalue some groups in order to create superiority in others. This happens by turning difference into inequity based on things like gender, age, sexual orientation, class, race, or ethnicity. And this then leads to social exclusion of certain individuals or groups. So I just want to quickly talk about discrimination specifically. So a lot of times people conflate the two terms and really sort of talk about them together as if they're one and the same, but they're actually quite distinct concepts, and they need to be distinguished in order to successfully respond and reduce them. So in recent years, the definition of discrimination has changed to clarify how it's distinct from stigma. So we now define discrimination as the experience of stigmatizing behaviors that fall within the purview of the law. So basically, these are actions that are illegal in a given context. And this can include things like losing housing or a job due to one's HIV status or being physically assaulted. So previous definitions of discrimination were much broader. So for example, UNAIDS defined discrimination as the unfair and unjust treatment of an individual based on the real or perceived status or attribute, which could include a medical condition, belonging, or being perceived to belong to a particular group. So I'm going to come back to this distinction later, but I just wanted to give you that basic background now. Okay, so there's quite a long history, actually, to the framework that I'm going to present today. It really began with work back in 2009 at a meeting hosted by or supported by UNAIDS. And shifted over the years to really incorporate what we were learning from STRIVE research, as well as other research that was published on how stigma operates and how we can intervene to mitigate it. So back in 2009, we held a meeting in Washington, D.C. with a number of stigma measurement colleagues, and this meeting was sort of the result of a need to be able to measure HIV-related stigma in a standardized way. There were literally thousands of items that had been used to try and assess stigma, and it was getting pretty confusing for researchers, and it really wasn't helping us to get where we need to be in terms of really being able to do something about stigma at scale. And so this group of researchers that got together, including James and probably some others who are on the phone here, we decided that one of the things we needed first was really a framework. We needed a framework to help guide us so that we could understand what is the stigmatization process, and how can we really make sense of it in a practical way so that we know where to intervene, and other researchers and policymakers will know where to intervene. So what you see here on this slide is really the initial framework that emerged from that work. It basically starts with what you see on the bottom: actionable drivers and facilitators, things that are kind of driving the stigma process, moves on to stigma marking, which then influences manifestations, outcomes, and impacts. I'm not going to go into detail here at the moment because I will do so when I get to the new framework. But you can see here that we have this process laid out. And the idea was that this process is happening and it's influencing the general population. It's influencing family and peers, people living with HIV, and key populations and institutions and structures. And we went on to then, through Strive, test this framework in India. And we worked with several program implementers who tested out the framework and gave us a lot of feedback. And so we did some tweaking of that work in, I think it was about 2013, 2014. So this was really the initial, where we initially started. Fast forward a few years, just to 2017, and the Fogarty Center at NIH hosted a meeting that was on health stigma broadly. So the idea behind this meeting was that NIH was really interested to see there's a lot of research being funded on different types of disease-related stigmas, disease and health condition-related stigmas. So the idea was, what can we learn from each other? Can we learn something from each other? And can we be more efficient and effective in working together to reduce stigma and discrimination, and in so doing, have improve health outcomes across a range of health conditions? And so I was asked to present the HIV stigma and discrimination framework at that meeting, really just sort of as food for thought, just to see, did it resonate with other health stigma researchers and so on. So luckily it did really resonate with other health stigma researchers in the room. And we decided after that meeting that it would be important to produce a journal supplement on health stigma and discrimination broadly, to really kind of make the case for the need to begin to work together across disciplines, across diseases, and so on. And so I was asked to lead a paper, the development of a paper and a framework so that it would be a broad health stigma and discrimination framework that would apply to multiple diseases and not just HIV. So that's the backstory to what I'm going to present to you now. So researchers studying health-related stigma have tended to focus quite narrowly on a specific disease or health condition. So this approach has really led to theoretical silos. So despite the fact that the stigmatization process is really fairly similar across health conditions and contexts. So for example, when we were working on our paper and looking up all of the theoretical frameworks that were out there, we found 7 obesity stigma frameworks, 7 HIV stigma frameworks, and 5 mental health stigma frameworks. So you can see that there's quite an abundance of theory out there, so it's important for us to look at that and see, how can we maybe streamline some of this. So in terms of current challenges with the frameworks that are out there, health stigma frameworks are typically specific to one condition, health condition, as I said, and they tend to concentrate on psychological pathways among individuals. Very few explore the social and structural pathways leading to stigma, even though, as I mentioned at the beginning of the presentation, those are actually quite important in shaping how stigma emerges. And as a result of this, current health stigma frameworks really limit researchers' ability to inform the multi-level interventions that are required to meaningfully influence the stigmatization process. This siloed approach really impedes comparisons across stigmatized conditions. It also impedes research on innovations to reduce health-related stigma and ultimately improve health outcomes. So in response, we developed a new framework called the Health Stigma and Discrimination Framework. The framework builds from existing conceptualizations of health-related stigma and from practical experience of the co-authors in designing stigma reduction interventions for a range of health-related stigmas. I just want to take a moment here to acknowledge my co-authors, who you see pictured here on this slide. It was really such an honor to work with some of the world's great thinkers on this topic. Collectively, we brought experience from stigma research on mental health, HIV, leprosy, cancer, tuberculosis, and obesity. And I think the resulting framework really benefits from that diversity of experiences. Our intent was really to provide a broad orienting framework akin to Perlin's stress process model to give conceptual organization to diverse lines of research that are underway across disciplines. So without further ado, here's the framework. I'm going to spend several minutes on this slide in order to walk you through the process and define some of the key terminology. So the Health Stigma and Discrimination Framework articulates the stigmatization process as it unfolds across the socioecological spectrum in the context of health. And this can vary across economic contexts in low, middle, and high-income countries. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, and stigma manifestations, which influence a range of outcomes among affected populations as well as organizations and institutions that ultimately impact health and society. So the first domain refers to factors that drive or facilitate health-related stigma. The drivers can vary by health condition, but they're conceptualized as inherently negative. So they can range from fear of infection through casual contact for communicable diseases to concerns about productivity due to poor health for chronic conditions to social judgment and blame. Facilitators, however, can be positive or negative influences. So, for example, the presence or absence of occupational safety standards and protective supplies in a health facility can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. So drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or other perceived difference, which could include race, class, gender, sexual orientation, or occupation. Intersecting stigma occurs when people are marked with multiple stigmas. And I'll come back to that in a bit. So once a stigma is applied, it manifests in a range of stigma experiences and practices. Stigma experiences can include experienced discrimination, which refers to stigmatizing behaviors that fall within the purview of the law in some places. I mentioned a few of these earlier, refusal of housing and so on, and experienced stigma. And that is stigmatizing behaviors that fall outside of the purview of the law. So basically verbal abuse, gossip, those types of things. And the legal distinction is actually really important because often there are different types of interventions depending on whether something that happened to you is legal or not. And so that's why we added that legal distinction in there. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with his or her stigmatized status. Perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetrated by others if their health condition becomes known, are also classified as stigma experiences in our framework. And lastly, secondary or associative stigma, which refers to the experience of stigma by family or friends of members of stigmatized groups, or among healthcare providers who provide care to members of stigmatized groups, is included under stigma experiences. Stigma practices can include stereotypes, prejudice, stigmatizing behavior, and discriminatory attitudes. In the framework, we consider stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. We postulate that stigma manifestations go on to influence a number of outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience, or the power to challenge stigma, and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protection. So while the framework is specific to health-related stigma, it recognizes that health-related stigma often co-occurs with other intersecting stigmas, such as those related to sexual orientation, gender, race, occupation, and poverty. And incorporating intersecting stigmas into the framework is really necessary, as stigma manifestations and health outcomes may be influenced by a range of stigmatizing circumstances that must be considered to understand the full impact of stigma. So what's different about the new framework? The Health Stigma Discrimination Framework differs from many other models in that it does not distinguish the stigmatized from the stigmatizer. The absence of this dichotomy is intentional because we're seeking to challenge the us versus them distinction that enables people to set others apart as different from the norm, which is a key component of the stigmatization process. We're seeking to move away from psychological models that see stigma as a thing which individuals impose on others, and instead emphasize the broader social, cultural, political, and economic forces that structure stigma. Removing the us versus them dichotomy also makes the framework more palatable to change agents, such as community leaders, advocates, and policymakers, as it highlights that all persons can act as change agents and really underscores the need for self-reflection and awareness of biases. Another difference from previous frameworks is the separation of manifestations into experiences and practices. This distinction clarifies the pathways to various outcomes following the stigma marking phase of the process. So, for example, those who experience, internalize, perceive, or anticipate health-related stigma face a range of possible outcomes, such as delayed treatment, poor adherence to treatment, or intensification of risk behavior that can diminish their health and well-being. Stigma practices, on the other hand, highlight how the stigmatization process can generate or reinforce stereotypes and prejudice towards people or groups living with or at risk of various health conditions, and foster discriminatory attitudes that then fuel social inequalities. So we also differentiated outcomes for affected populations, or the stigmatized person or group, as well as their family and friends and so on, from outcomes for organizations and institutions. Our framework really seeks to demonstrate that stigma experiences and practices influence both affected populations and organizations and institutions, which then together affect the health and social impacts of stigma. And by articulating these outcomes, the framework highlights the need for multi-level intervention to respond to health-related stigma, and also focuses attention on the far-reaching influence of health-related stigma on societies as well as individuals. So how do we use the framework? One way is to guide the development of intervention. So in terms of where to intervene, ideally we want to stop stigma marking from occurring. So a lot of interventions focus on the drivers and facilitators of stigma. For example, mass communication efforts may be used to help populations better understand a health condition and dispel myths about how a disease is transmitted and who's at risk. Similarly, new policies could be developed and implemented in healthcare facilities to ensure that patients with a specific health condition like HIV aren't identified in any way, for example, through special colored files. While we'd like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition, or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. So I just wanted to remind everyone that in terms of HIV-related stigma specifically, we actually have a lot of evidence on interventions that are effective at addressing these different drivers and facilitators that we were just discussing. And so I just wanted to highlight that here and let you know that there are a lot of Strive resources out there on the website and other publications that have that give an overview of these types of interventions. So in terms of other ways that you can use the framework, in addition to helping to design interventions, it's really our hope that the framework will enable stigma researchers across disciplines to standardize measures, compare outcomes, and build more effective cross-cutting interventions. In addition, researchers can use the framework to generate research foci, to explore multiple health issues, and consider the interaction between multiple identities, social inequalities, and health issues. So the framework can also point to areas where clinicians, program implementers, and policymakers can focus greater attention to better meet the needs of and improve health outcomes among their clients, communities, and societies more broadly. Implementation science approaches can advance how we tailor and apply the framework to guide stigma discrimination reduction interventions and policies. So, for example, in defining who the target audience is for change, what specific drivers and facilitators of stigma should be addressed, what intervention or policy components are appropriate to address them, and how to measure change in specific outcomes over time. So in order to demonstrate the cross-cutting nature of the health stigma and discrimination framework, in the paper we examined how it applies to both communicable and non-communicable health conditions. So I'm going to share 3 of these examples with you now. So let's start with leprosy. So leprosy is perhaps the oldest stigmatized health condition. Drivers of leprosy stigma include fear of contagion, social exclusion, and disfigurement, as well as beliefs that the person with leprosy has sinned or broken taboos. In terms of facilitators, social inequalities really come into play here. So, for example, people affected by leprosy often have a low socioeconomic status, low or no education, and low or no awareness of human rights, which really heightens their risk of discrimination. So in South Asia, a low caste background can add an additional intersecting layer of stigma, and this is the case for many women in many endemic countries. The stigma attached to leprosy typically manifests as a spoiled identity in the affected person, affecting status and reputation both for the individual as well as their family members. Social participation can be severely restricted, including problems in finding or keeping jobs, reduced access to education, or reduced opportunities in finding a marital partner. Many people affected would seek to conceal their condition. But this concealment causes stress and anxiety, and also may cause people to delay presenting for diagnosis and treatment. When treatment is delayed, this may increase the severity of disability. Some people may opt to discontinue treatment rather than risking being found out. And really, at the personal level, these outcomes of stigma lead to a number of negative impacts for people living with leprosy, including reduced quality of life and mental well-being, which includes an increased risk of anxiety and depression for people living with leprosy. At the organizational level, leprosy-related stigma outcomes may include poor quality of health services and increased staff turnover. And finally, at the societal level, the combined impact of these outcomes may be prolonged transmission of the bacilli in the community. So let's turn now to HIV. So HIV, in terms of drivers, there are several key or common causes, drivers of HIV-related stigma. These can include fear of infection through casual contact with people living with HIV, a lack of knowledge and awareness of HIV. Can include things like fear of economic ramifications due to the chronic nature of HIV, and fear of poor productivity and longevity. Facilitators of HIV-related stigma include things like laws that criminalize HIV infection, unenforced protective laws regarding key populations, the lack of availability of universal protection supplies and health services, and prevailing norms about populations most vulnerable to HIV infection. HIV stigma often intersects with other stigmas, specifically related to sexual orientation, occupation, race, and substance abuse. HIV-related stigma typically manifests in a number of experiences such as social rejection and distancing, gossip, poor healthcare, internalization of stigma, secondary stigma for families and healthcare workers, providing care to people living with HIV. And in terms of practices, HIV stigma often manifests in discriminatory attitudes about people living with HIV, and really a reinforcement of these stereotypes and prejudices. Outcomes of these manifestations for affected populations are really related to things like risk behaviors, HIV testing, engagement and retention in care, and initiation and adherence to medication. For organizations and institutions, on the other hand, HIV stigma can manifest in HIV-related laws and policies. So these could include things like criminalization of transmission, travel restrictions, workplace policy, pre- and in-service training curricula for healthcare providers and other duty bearers. So all of these manifestations can really go on to ultimately impact HIV incidence, morbidity, and mortality, and social inclusion and quality of life. So the last example I want to go through is mental health. Mental health-related stigma is often grounded in stereotypes that people living with mental health issues are dangerous, responsible for their mental health issue, can't be controlled or recover, and should be ashamed. People living with mental health issues are often viewed as incompetent and unable to work or live independently. Negative public attitudes, opinions, and intentions persist and are really reported across diverse global contexts regarding having a person with mental health issues provide childcare, teach children, marry into a family, and so on. Race and gender appear to intersect with mental health-related stigma, really influencing its severity. The public stigma towards, for example, the public's stigma towards perceived masculine issues appears to be higher than perceived feminine issues. And there are also gender differences in perceived stigma where men may experience elevated stress regarding disclosing mental health issues in comparison to women. Common manifestations of mental health-related stigma are anticipated and perceived stigma, which really contribute to fear of acknowledging one's mental health issue and can lead to shame and avoidance regarding seeking mental health care. Mental health-related stigma has a profound influence on life opportunities and persons realizing their goals and potential. It's associated with lower self-efficacy and self-esteem and compromised engagement in employment and independent living. Public policy responses in some countries have gone a long way towards reducing the harmful effects of mental health-related stigma at the organizational and institutional levels. So, for example, in the United States, the Americans with Disabilities Act, which was enacted in 1990, called for preventing discrimination on the basis of mental health and social inclusion and participation of people living with mental health issues in society. So I just want to note here that the examples of drivers, facilitators, intersecting stigmas, and manifestations that I reviewed for leprosy, HIV, and mental health stigma are really intended to be illustrative. Researchers, clinicians, program implementers, and policymakers would really need to ascertain the most relevant aspects of each of the domains of stigma in their context, or with the specific population they're working with, in order to apply the framework in support of stigma and discrimination research and reduction efforts. Here we go. I was having trouble moving the slide forward. So in conclusion, we're really at a critical moment when cross-disciplinary and cross-disease research and collaboration are needed to tackle health-related stigma and its harmful consequences. Our hope is that the Health Stigma Discrimination Framework will facilitate such collaboration. We believe that research and interventions inspired by a common framework will enable the field to identify commonalities and differences in stigma processes across diseases and amplify our collective ability to respond effectively and at scale to this major driver of poor health outcomes globally. I just want to take a minute for a few acknowledgements. Firstly, I just want to thank the NIH Fogarty Center, and in particular, Nalini Anand and Ariane Malexade, for their really leadership and guidance in this whole process for the BMC supplement. I also want to thank the William and Flora Hewlett Foundation, who provided support for the writing of the paper, as well as UK Aid from the Department of International Development. And then also I'd like to thank my co-authors and, of course, my amazing Strive research colleagues who I'm going to miss dearly after this ends. There's been a lot of strong collaboration over the years and improvement and thinking about HIV-related stigma, and which has really led us to this point where we have this new framework. I'll leave this up here just so you have it on the slides. These are a few recommended resources. You can also track many of these down on the Strive website. And I just want to point out for those of you, for everyone on the call, that we're having several dissemination events for Strive that are coming up. One of which is tomorrow, and if you happen to be in Mwanza, Tanzania. There's one on March 28th in Delhi. We're having one in Washington, D.C. on April 4th. And finally, there's one in London on May 17th. So if you'd like to, we'd love for you to come to any of these dissemination events if you're able to, and really get a full picture of all that we've learned from these 8 years of Strive. So I have that information up there in case you can contact Annie Holmes if you need more information. So with that, I'm going to just open it up for questions and comments. And thank you all for your time.
So firstly, thank you very much indeed on behalf of everyone on the call. That was wonderful. Thanks for a very thorough description. We're open for questions, everyone. I'm going to remind everyone to do what I just forgot to do, which is press *7 to unmute yourself if you'd like to ask a question. And you can also put questions or comments into the chat box if you'd like to do so. I don't have any questions at the moment, although please do shout or put your hand up on the screen. So maybe I can start off, Anne. So thank you very much indeed. I suppose there were two things that I wondered if might have been tensions as you were doing this work, and I just wondered if you might want to comment on both of them. The one is, I suppose, it's really great, your new framework, but I suppose there must be a bit of a tension in responding to the fact that there's lots of frameworks by coming up with a new framework. And I just wanted to get you to say something about, how that proliferation of frameworks is working, whether or not you think there's particular buy-in for this one, and this is going to be the one, because I know you're aware of that as a problem, and just a few comments on that kind of, how do we stop, or is it a good thing that there's this, there are many frameworks out there? And the second question is whether or not you wanted to comment a bit more on this interesting decision that you've made about trying to get away from this distinction between the stigmatizer and the stigmatized. And I think I understand where that's coming from, but I wanted you to maybe say a little bit more about that, because it's certainly true, isn't it, in many cases that there are people who experience stigma and those who propagate it. And I just wonder if you want to say anything about any risks associated with breaking that distinction. There's two questions to get us going while other people are thinking.
Sure. So on the first question, it is always tricky to come up with sort of a broader framework, especially given that there is such a strong really research tradition of looking at stigma and health conditions. And I will say that one of the reviewers of the paper also brought this issue up. So I think really that's why we decided to really sort of frame it in a similar way to Perlin's stress process model. So the idea is not to say like this is the ultimate framework that everyone must now use, and obviously different researchers studying different diseases are going to, there's always going to be very disease-specific things. And if you're doing, for example, if you're a psychologist and you're doing much more psychological research and you're testing different pathways, then obviously you have to very clearly articulate what you think leads to, X, A leads to B plus C, all of that. And so I certainly wouldn't say that, I would hopefully want people to put down their frameworks and use this one moving forward. I think this really is meant to be a guiding framework. The idea is to really help to bring together researchers working on these different health-related stigmas. And it was interesting because it went very well in terms of the collaboration with my co-authors to develop the paper, but I wasn't quite sure how it would be perceived. But I've luckily had the chance to present it twice, once at a Fogarty Center board meeting, and then last week at the Social Behavioral Medicine Conference in Washington, D.C. And at the conference last week, I was really struck by how many people actually at the conference were doing research on other stigmas. So for example, there were presentations on diabetes, type 1 and type 2 stigma, on stigma associated with all different kinds of health conditions, obesity and others. And many people sort of came to the presentation and shared that this framework, they saw a lot of similarities in the work that they were doing. They thought it would be really helpful for them in thinking through. I think what happens is sometimes people they so hyper-focus on one thing that they might not be thinking, for example, about the structural factors that might be leading to, for example, diabetes stigma. Whereas, a framework like this kind of helps to remind people that, in addition to thinking about the individual and the health providers that you're trying to, shift their behavior and improve or remove their biases, you also have to think about the structures that are in place that are really, helping to foster those biases that we all hold. So I guess I'll stop there, but that's sort of our thinking on it to date. I guess it's only been out for a month, so we'll see what people think of it and how it's used. But so far I've gotten positive feedback. The second question you asked was about this decision about separating the stigmatized from the stigmatizer. This is tricky, and I have to say I really did have to argue hard for this one with some of my co-authors. I think this kind of comes back to, I think, the type of research you're doing. Oftentimes, like I was saying, that researchers are looking at stigma as sort of this psychological process that's happening to an individual. And when you do it that way, it's much easier to sort of say, oh, okay, this person is being stigmatized, and there is someone who is doing the stigmatizing. And so for those that kind of research and modeling, it can be helpful certainly to sort of separate those two quite clearly. But from a broader research perspective and from a policy perspective, it's really unhelpful to have that in a framework because it really, when people see that, they think immediately, oh, if I'm not the stigmatized person, I must be the stigmatizer. So it sort of kind of stops discussion and conversation when you see that in this kind of a broad framework. So that was one of the reasons. And I really think we do want to, the way in which we're going to stop stigma, in a sense, is to help people see that they need to stop doing this separation, that they need to recognize that it's happening. It happens daily in all of our lives, that sometimes we are personally stigmatized, sometimes we are doing the stigmatizing, but we can be in either category at any time point. And so I think by removing it and just instead focusing on the actual things that are driving and facilitating stigma, the ways in which it manifests, I think it just really helps people to kind of see clearly, like, oh, I can intervene here, or this is something that I can do with my colleagues or my coworkers, or this is something that I can do with my fellow lawmakers. So I really think that it will be helpful ultimately to facilitate sort of this more cross-disciplinary research to remove that distinction. Okay, those are my long-winded answers. I see a question.
Great. Thanks, Anne.
Yeah.
That's wonderful. Jacqueline Devine, or Divine, apologies if your name, has written a question in the text box. Jacqueline, I don't know if you want to ask your question. I'm happy to read it out for you, but you want to ask it yourself? Chris is saying I should just ask it, so I will. Oh no, press *7. Yes. No, she doesn't want to read it out. Okay, so the question though is a good one. It says, great framework and congratulations. One question though is, how can the framework, or maybe it cannot be used to this end, support analysis for common drivers across areas? We still end up analysing by area, ending up in silos. Or is that not a useful exercise? I wonder if you could comment, Jacqueline, on that.
Yeah, thank you, Jacqueline. That's an excellent question, and it's actually one that we are going to be discussing in the next few weeks. At the Fogarty Center is going to be convening another meeting on this topic now that we have sort of furthered our thinking on how we might do this work together. I think the issue is we haven't yet. There aren't a lot of great examples of looking at sort of multiple disease stigmas together. And so I think this is going to be a bit of a learning process. I think one of the areas where it can be influential at first is really thinking about the intersectionality issues when you're looking at maybe race and a specific health condition, or gender, sexual orientation, those kinds of things. And I know in the field of HIV, there's definitely been some work to try to really unpick this intersectionality. One of the papers in the supplement that I mentioned, the BMC Medicine supplement, actually addresses the question of intersectionality. So I think my answer is really, I'm not quite sure yet, and stay tuned. I mean, I think we hope the idea behind the framework is that it would facilitate these conversations so we could see the commonalities, and we, could get, let's say, researchers working together on, for example, obesity and type 2 diabetes and race. This was something that came out of a whole session that I went to last week on diabetes stigma, and it was really fascinating to see how you could just see how all of these things were coming together to influence the experience of patients in that context. And I think interventions are going to need to address all of those things in order to improve patient outcomes. Now, that's not to say that, we have to get everyone together and work on every disease at the same time. So I think we need to, we clearly want to be smart about it and see what makes sense. But we're hoping that the framework can help us to do that.
Thanks, Anne. Does anyone else have a question online? I've got one more up my sleeve, but it'd be better if someone else asked one. While remembering that you have to unmute yourself, maybe while we're asking, I'll ask another one then, Anne. And that's about something that I've been grappling a little bit with recently, and you and I had a quick exchange about this the other day, is about the overlap or otherwise between the concept of stereotyping and the idea of intersecting stigmas. And I'm still kind of thinking this through myself. I'm just interested to hear you reflect on it. Certainly in HIV, for example, it seems to me that some of the stereotyping that happens, all of those people who've got HIV are sex workers, or all of those sex workers have got HIV. That's kind of stereotyping, but it's also related to this idea of intersecting stigma. And maybe you could say something about how you deal with those overlaps.
Yeah, that's definitely an interesting question. Let me see. I think, so in the framework, we really, as I mentioned, we put stereotypes in two different places, right? We put them as something that sort of drives the stigmatization process, and we also put it as something that, as a manifestation, because a lot of times these things are sort of reinforcing. If we're hearing people, or if we're seeing things in the media that seem to suggest that, it's only injection drug users who are at risk for HIV, for example, or, those kinds of things, where we see certain language that's about how people talk about people with a certain health condition, that really is kind of reinforced. They sort of reinforce one another. So that's one of the reasons why we put it in both places of the framework. Now, I do agree that obviously this prejudice and stereotyping that we all do, it really is kind of fueling this intersectionality, and I think often affects particularly marginalized populations, people who don't really have social support and power to sort of fight back against the stigma they're experiencing. I'm not sure. So in the framework, we talk about intersectional stigma as sort of, when people are marked with multiple stigmas. So, and then we go on. And so in terms of interventions, I think what you would need to do there is look at sort of, is it a stereotype that is driving a certain aspect of intersectional stigma for a specific health condition? And if it is, how are we going to address that stereotype? What are we going to do in order to try and remove that stereotype or get people to think differently? So I think it's sort of a useful tool to think about as one of the drivers, but I don't think it's the only driver. And I think also sometimes some people might be more, have stronger prejudices and stereotypes than others, and maybe their stigma about a certain health condition is more driven by fear than it is by prejudice or stereotype. So again, I think researchers and people sort of looking to address intersectional stigmas are really going to have to kind of map out what are the different aspects, what is driving this, what is facilitating this, how is this manifesting, and what can we hope to do about it. So I'm not sure if that answers your question, but that's kind of where I'm at in terms of my thinking.
That's great. No, thank you, Anne. That's wonderful. We've got one more question on the text thingy from Holly. Holly says, thanks for the presentation. You just said that interventions would ideally address all of the types of stigma identified in your model. I'm wondering whether there are obvious ones that you might address first in a first attempt at addressing stigma.
Yeah, so I think what I meant to say is that you wouldn't, basically you would have to sort of decide what's most important in your context. So I think, and also depending on the kind of finances that you have to support your interventions and where you need to target. But for example, if you're really trying to target the drivers and facilitators, you're going to need sort of much larger level interventions that might include mass communication, or it might include developing training programs for people in, being trained to be physicians or police officers or those kinds of things. And also structural interventions, working with policymakers to shift harmful laws to make sure that protective laws are enforced. But in your particular situation, it could be that you're very focused on, you have a very specific population. You've got transgender women in a specific context, and they're being treated very poorly, and you need to go in with social support interventions and interventions that are going to really support resilience. So I think it's not to say that everybody looking to reduce stigma has to address all of these things. It really depends on your context, your population that you're working with, your focus, what do you think is the most important need? And ideally, no one can really do all of this, but if many people are addressing or tackling different aspects, I think that's helpful. And then the last thing I would say there is just one thing that we know from years of stigma reduction research is just that working at multiple levels, which is why we have that socio-ecological framework kind of in the background, or the framework overlies that. It's in there for a reason, because you can't just work with individuals. You can't just work with communities. You really have to work across as much as possible in order to really make good progress.
Wonderful. Thanks, Anne. We're getting to the very end of our time. We maybe have time for one more question if someone has one. And if they don't, then I think we will close. So firstly, we should say an enormous thank you to Anne for a really clear and a nice presentation. Thank you very much indeed. Thanks everyone who's on the line for participating in the Learning Lab today. The presentation for this Learning Lab, and I think all of the other ones that there ever have been, are on the Strive website. And I have to ask you in my nicest possible voice if you'll just spend 1 or 2 minutes after the call filling out the feedback form, which will appear on people's screens. Is that right? When the call ends. It's incredibly helpful for Strive if you do that, and we'd be very grateful if you would. So with that, I think we can log off. Thanks, Anne. Thanks, everyone else, for attending, and enjoy the rest of your day.
Thanks, everyone. Bye-bye.